So, when it comes to managing my patient's care, I definitely use pharmacodynamic thinking a lot. And I guess it really is a lot of times kind of unbeknownst to myself. So, for a lot of our post-operative patients, um, we use all sorts of different kinds of medication. We use opioid analgesics, we use NSAIDs, benzos, muscle relaxants, um, gabapentin for nerve pain, all these different medications to try to treat just pain. Um, so you really have to think about how everything interacts and how everything can affect the patient. So, for example, in terms of potency, for our IV analgesics like IV fentanyl, you're going to give 12.5 micrograms for like the small end of the dose, um, or even less in a like a PCA or something. And if I give IV morphine, it's going to be 1 or 2 milligrams. So, I mean, that's a hundredfold difference right there. So you really want to think about that, as well as like benzodiazepines. Whether it's Ativan or Valium, Xanax, clonazepam, they all have kind of different potency. But then what's more important is the efficacy. So in terms of, again, opioid and analgesics, like, Dilaudid, everyone's like, oh, yeah, that's the best. When you compare it to fentanyl, um, we kind of, for like PCAs, we'll start with a fentanyl, and if it's not working well, we go up to the Dilaudid because we think it works better usually. Um, and then also, like with benzodiazepines for as a muscle relaxant, we want to use Valium because it's far more efficacious than the other benzos. Or when you just look at the hierarchy of muscle relaxants, we have like Xanaflex and Flexeril and Robaxin, and there's just this little hierarchy where Robaxin's kind of like the lowest, and then Xanaflex and Flexeril and Valium's the top dog. So we know that that's usually more efficacious, but with that efficacy comes a lot of times can be side effects, or it can when it interacts with the pain medicine, it has a potentiating effect. So we just need to be careful about everything. Um, when thinking about median effective dose, so in my post-op population, we do a lot of, say, back surgeries. Patients have chronic pain. They've gone to pain management doctors, and they've built up somewhat of a tolerance to pain medicine, analgesics. So a lot of times our median effective dose for these chronic pain populations are so much higher than what you would see in the normal population because of tolerance. So that's something a lot of times we have to think about, and ask our patients, what have you been taking before surgery for pain? Did you have a period where you tried to wean off some of that so that we've got something to work with here? So thinking about the median effective dose principle and also the dose response relationship. So for the individual patient, um, you know, again, a lot of times we try to start with the fentanyl before the Dilaudid and the PCA, or Ultram or hydrocodone before we bump up to oxycodone, or even a low dose of oxycodone, say 5 milligrams, and bump up to 10 or 15 if they're not getting the therapeutic response that we expect. So what you want to do is just start low, and find that perfect dose in the phase 2 of the dose response relationship, where you don't have a super high dose going into phase 3. That's where if I'm giving somebody 15 milligrams of oxycodone and they start getting all zonked out and they're not breathing deeply, that's a risk, big risk there, and we don't want to go to that level if we can use kind of the lowest therapeutic dose possible. So I think about all those pharmacodynamics, all the time. I guess not explicitly. But I do use it, with all this pain management for these post-op patients. In terms of pharmacogenetics and analgesia, um, it's there's really a lot of research out there, and I mean, I can see it myself in such wide variance of responses to different pain medicines, different dosages. People respond so differently to anesthesia. They respond differently to opiates, IV opiates, I mean, just everything. For some people, oxy sucks, and something like Ultram is great, but it shouldn't really be that way, theoretically. But when you think about pharmacogenetics, um, people can have different enzymes and reactions and makeups of their bodies that change the way we metabolize and the way that we use these medications. So, for example, there was research in 2009 by Kudzma and Carey um, talking about pharmacogenetics. Really interesting article, but within it was specifically talking about codeine and how it's only activated when the body metabolizes it into morphine. But the body uses an enzyme, CYP2D6, to metabolize that. And then there's another enzyme, CYP3A4, which is an enzyme that helps clear the codeine out of your body as well as your renal activity. So when you first take codeine, about 10% is actually metabolized. 80% is taken out of your body by the clearance enzyme and your renal, your kidneys. So you really have only about a 10% effect of what the actual dose of codeine is. Um, but let's say the patient in their genetics has ultra rapid metabolizer, which can be a genetic variation of the CYP2D6 enzyme for metabolism. So let's say they have this ultra rapid metabolizer and they have an inhibited CYP3A4 enzyme, which would impair clearance, of that medication. You're at a greater risk for intoxication and the nasty side effects of opioids like respiratory depression um, and just making your patient totally lethargic and stuporous. So it's really important that we kind of think about, how is our patient's genetic makeup going to respond to these codeine medications? And then the other hand, other end of it is about 7 to 10% of the Caucasian population have a mutant non-functional like alleles within that CPY2D6 enzyme pathway, and that will inhibit the codeine conversion. So you won't have a therapeutic response with the medium effective dose, or maybe even higher. It might take a lot more for the patient to actually begin to metabolize in a therapeutic level of the codeine into morphine. So it's really, really interesting. Pharmacogenetics, I think, is going to explode, and I'm really excited about the future. So I look forward to hearing what you all have to say about it.